Hello, this is Dean Sittig from the University of Texas School of Biomedical Informatics in Houston, Texas. It's a pleasure to be invited to participate in this debate of the motion that health information technology is already improving healthcare safety and that current regulation around it is sufficient. It's an honor to be paired with such an accomplished clinician and health services researcher as Aziz Sheikh against such worthy opponents as Ross Capel and Guy Mattern. By way of background, I obtained my PhD in biomedical informatics from the University of Utah back in 1988, where I worked at the LDS Hospital, part of the Intermountain Healthcare System, under the direction of Reed Gardner, Homer Warner, Alan Morris, and Terry Clemmer. Over the last 30 years, I have been working on the design, development, implementation, use, and evaluation of all aspects of electronic health record related technology. Over the past 15 years, I have participated in many qualitative research projects with both Joan Ash from the Oregon Health Sciences University in Portland, Oregon, and Hardeep Singh from Baylor College of Medicine that examined the pros and cons of computer-based provider order entry with clinical decision support, unintended consequences of health information technology use, and more recently to develop the SAFER guides to help organizations understand and utilize best practices for safe and effective electronic health record use. In short, applied clinical informatics is my life. This is a two-part motion. The first part, that health information technology is already improving patient safety, seems abundantly clear to anyone who can even remotely remember what healthcare was like in the pre-computer age. First, the complete record was not available for the majority of patient care interactions due to it being in a different physical location than the patient. At Kaiser Permanente in the Northwest region in the late 1980s, they implemented the one patient, one chart philosophy across their 30 patient locations in the Portland metro region. This involved a large fleet of vans, which eventually numbered over 70, that attempted to drive the patient charts around to the various clinic locations based on the upcoming day's patient schedule. As one might imagine, even after considerable rework, many systematic improvements, and significant increases in number of vans and drivers, they were never able to achieve greater than 75% success. While current EHRs are not 100% foolproof and computer interpretable interoperability still has a ways to go, within Kaiser Permanente, for example, access to the patient's chart is a solved problem. And for the most part, in other healthcare delivery systems around the world that utilize advanced electronic health record technology, clinicians now routinely have access to the majority of their patients' charts at most visits. Second, the EHR has virtually eliminated the problems associated with illegibility. Extensive studies of medical chart legibility in the paper-based environment found at least 10% of the charts unreadable. While the current EHR charts may seem long, unorganized, and difficult to navigate, they are a significant improvement over the handwritten mess that used to pass for a medical record. Therefore, in terms of the most basic aspects of patient safety, a record of patients' previous medical history, we have made significant strides in improving access and readability of the chart, which form the cornerstone of health information technology-enabled patient safety. Third, before one can manage or even study a problem, one must be able to accurately measure the extent of the problem. While many have argued that we are making errors in the current EHR environment, in the paper-based era, such research projects were almost impossible to conduct. Record reviews of more than 1,000 charts were seldom accomplished in the paper-based days. In fact, the 1999 Institute of Medicine report on medical errors was based on the review of less than 15,000 records. Today, with a state-of-the-art EHR, we can scan 100,000 charts looking for potential errors before our first cup of coffee. This newly acquired capability to measure and monitor so many aspects of medical care has already had a significant positive impact on the safety of healthcare, and this will only increase as we learn more about how to collect and interpret these large databases. So in my mind, at least, there is really no way to argue that patient safety is not improved by at least 10 times and probably closer to 100 times since the widespread use of electronic health records over the last 10 years. The second part of the motion, that current regulation is sufficient, is also very interesting to me. Before we delve into this part of the motion, I think we need to clearly define the terms we are arguing about. Most people would agree that there are two basic kinds of errors associated with EHR-related patient safety: errors of commission, or doing something wrong, and errors of omission, or which is failing to do the right thing. Both can lead to undesirable outcomes or increase the potential for patient harm. For instance, ordering a medication for a patient with a documented allergy to that medication would be an error of commission. On the other hand, failing to prescribe a proven medication with major benefits for an eligible patient, for example, providing a prescription for aspirin, a statin, beta blocker, or an ACE inhibitor at hospital discharge for a patient with acute coronary syndrome, would represent an error of omission. Errors of omission are often more difficult to recognize than errors of commission, but they likely represent a significantly larger problem. Most researchers, think of the Beth McGlynn study that was published in the New England Journal of Medicine, have found that there are many more instances in which provision of additional diagnostic, therapeutic, or preventive modalities would have improved care more than there are instances in which the care provided quite literally should not have been provided at all. In many ways, this point echoes the generally agreed upon view in the healthcare quality literature that underuse of medical care far exceeds overuse, even though the latter has historically received far greater attention. Current electronic health record legislation is working on reducing errors of commission. We mandate drug allergy, drug, and drug duplicate checking at the time of order entry. Based on the literature, these relatively simplistic forms of clinical decision support are not working very well, as evidenced by the extremely low rate of user acceptance, far less than 10% in most reports from healthcare organizations. It is hard to imagine that more legislation at this time is the right way to go to try to reduce the number of errors of commission that we make. In addition, there is much work going on using data extracted from EHRs to study errors of commission. We also have isolated cases of the use of advanced clinical decision support to address these types of errors. Think about the venous thromboembolism prophylaxis checking system that are run on every patient following admission to the hospital. At this point, there is still much disagreement on what constitutes the appropriate or even required care for patients. Experts have argued that less than 50% of medicine currently practiced is based on evidence. Therefore, it is clearly way too early to argue for more legislation in this area. Patient safety can also be described according to the terms active versus latent errors. These terms were coined by James Reason in the 1990s to refer to different types of errors. Active errors occur at the point of contact between a human and some aspect of a larger system. For example, the electronic health record's human-computer interface. They're generally readily apparent. For example, pushing an incorrect button or ignoring a pop-up warning, and almost always involve a clinician at the point of care. Active failures are sometimes referred to as errors at the sharp end, figuratively referring to the scalpel that a surgeon would hold. Errors at the sharp end are often noticed first because they are committed by the person closest to the patient. This person may literally be holding the scalpel, an orthopedist operating on the wrong leg, or by a nurse programming an intravenous pump to administer a pain medication, or using a barcode medication checking device before administering a medication. Latent errors, in contrast, refer to less apparent failures at the organization or design level that contributed to the occurrence of errors. To complete the metaphor, latent errors are those at the other end of the scalpel, the blunt end, referring to the many socio-technical layers of the healthcare system that affect the person holding the scalpel. Our current studies of patient safety surrounding the use of EHRs most often focuses on the first category, active errors. Ross Capell has done a wonderful job documenting the multitude of ways that EHR users make these sorts of active errors. While there is some evidence on ways to make computers in general, and EHRs in particular, less prone to allowing these types of errors, there are a multitude of additional issues in the current complex socio-technical healthcare environment that also place enormous pressure on clinicians that must also be addressed if we are to eliminate active errors. Legislating one aspect of the problem, electronic health record user interfaces, for example, and not any of the others, such as cuts in reimbursement, our current focus on patient safety over quality of care, long duty hours, etc., will not by itself solve the problem. Before we enact additional legislation, we need to better understand the entire socio-technical problem so that we don't inadvertently make the current situation worse. Finally, researchers in patient safety often discuss slips versus mistakes. Errors can be categorized as slips mistakes based on the cognitive psychology of task-oriented behavior. Slips refer to failures of behaviors or lapses in concentration. For example, overlooking a step in a routine task due to a lapse in memory, or an experienced clinician clicking on the wrong button during the entry of a pain medication order and inadvertently ordering too much of the wrong form or the wrong dose of a medication. Slips occur in the face of competing sensory or emotional distractions, fatigue, and stress. Reducing the risk of slips requires attention to the designs and protocols, devices, and work environments. Using checklists so that key steps will not be omitted. Reducing fatigue among personnel. Removing unnecessary variation in the design of key devices, or eliminating distractions. For example, cell phone use by anesthesiologists during surgery. Slips can be contrasted with mistakes, which reflect failures that require conscious thought, analysis, and planning. Mistakes typically involve insufficient knowledge, failure to correctly interpret available information, or application of the wrong cognitive heuristic. For example, choosing the wrong diagnostic test or ordering a suboptimal medication for a given condition represents a mistake. Mistakes often reflect lack of experience or insufficient training. Reducing the likelihood of mistakes typically requires more training, supervision, or occasionally disciplinary action in the case of negligence. Unfortunately, healthcare has often responded to all errors as if they were mistakes, with remedial education, added layers of supervision, or in this case, a proposal for additional legislation. In point of fact, most errors in healthcare are actually slips, which occur due to fatigue, stress, or emotional distractions, and can only be prevented through sharply different mechanisms than the ones we are proposing today. Once again, using this terminology for studying patient safety, it seems clear to me that current legislation is sufficient and is way too early for additional legislation to try and eliminate either of these types of slips or mistakes. By way of rebuttal to Ross's arguments, Ross mentioned interoperability as a cause of patient safety events. I think he was referring to computer interpretable interoperability, which is not necessary for first-level patient safety. The ability for clinicians to read the notes, which does not require thorough computer interpretable interoperability, is sufficient to reduce duplicate testing and prevent many inadvertent medication orders. Attempting to legislate interoperability by focusing solely on EHR vendor actions, is irresponsible. The current challenges to interoperability once again consist of a mishmash of socio-technical problems that must be addressed to solve the current problem. For example, the failure of the U.S. government to allow discussion of a unique patient identifier is unconscionable. Furthermore, in the current fee-for-service or pay-for-quality rather than pay-for-quality environment in the United States, there is little incentive for most healthcare facilities to actually share patient data. In fact, if they were to share data and reduce the amount of duplicate testing, their revenue would fall and many would be forced out of business. He mentioned usability. While I agree it is not what we want, it is still much better than what we had with the paper record. Once again, with our limited understanding of what makes an EHR usable, and better yet safe to use, it is way too early to mandate usability. Anyone that believes otherwise should try a quick thought experiment and try to come up with a simple, easily implemented, and enforceable rule surrounding EHR usability other than those already suggested in the SAFER guides that Aziz already mentioned. For example, the SAFER guides recommend that the patient ID should be displayed on all screens and that all laboratory graphs should have a clearly specified, easily understood X and Y axis label. Ross also mentioned functionality. Again, this is not what we want or what we need with the current EHRs, but is still far better and far safer than the paper-based system. Ross says that safety is not addressed. I disagree. Finally, Ross states incorrectly that medication errors are the biggest problem in patient safety. This is not true. Diagnostic errors are the biggest problems in terms of harm to the patient and cost to the healthcare system. So in summary, the current state of healthcare safety, while not perfect, is a vast improvement over the paper-based environment. Again, I would estimate 10 times to 100 times safer than before. Second, the current level regulation is not only sufficient, but clearly the best we can do given our limited understanding of the overall socio-technical problem. Perhaps even more important is the risk to patient safety due to our limited understanding of any unintended consequences that might arise due to inappropriate additional legislation. Thank you.